have our pleasure and great honor to introduce our second speaker, Dr. Mohammad Aljawad. Dr. Mohammad Aljawad is a colleague, he's a gastroenterologist and transplant hepatologist. We're going to speak about HPV reactivation risk and management during immunosuppression. He is from King Fahd Center of Transplant in Dammam. Mohammed, please.
Thank you for the nice introduction. It's my pleasure and honor to be presenting today. My presentation will be about hepatitis B reactivation during immune suppression. So I'm going to start off with a few cases that we routinely see in the GI and liver clinic. First case is a 28-year-old male with ulcerative pancreatitis. Patient was symptomatic despite receiving different modalities of treatment, including steroid, 5-ASA, and azathioprine, and it's time to consider anti-TNF for him. His hepatitis B profile showed the following. His hepatitis B surface antigen was positive, core antibody was positive, his hepatitis B DNA was undetected. There's no voting, but you can just think about what's the best answer here. So do you think this patient not at risk because he is inactive carrier? Low risk, we just need to monitor his hepatitis B profile during treatment, or he needs prophylaxis with vaccine, or prophylaxis with anti-HPV. What if we change the serology a little bit? If the patient surface antigen is negative, but he does have hepatitis B surface antibody with core antibody positive, DNA still undetected. At this time, do you think this patient is not at risk because he has natural immunity? Low risk, and he just needs to be monitored over time, or he needs prophylaxis with vaccine or prophylaxis with antiviral. Second case is a 60-year-old male, was diagnosed recently with non-Hodgkin lymphoma, and there is a plan to start him on rituximab-based therapy. This is his hepatitis B profile. His hepatitis B surface antigen is negative. He has surface antibody titer positive at 62, core antibody positive. So what do you think now? Do you think this patient not at risk because he has natural immunity? Low risk, and he just needs to be monitored over time. He needs prophylaxis with antiviral or need vaccination, or the risk is too high, and you need to discuss with your oncologist colleague to omit rituximab from the regimen. So my objectives will be to discuss the definition of hepatitis B reactivation, risk assessment, then discuss the management plan for a patient at risk for reactivation. So as Dr. Cow mentioned, hepatitis B is the most common chronic infection worldwide. It's been estimated that about 350 million are chronically infected with hepatitis B, and about 2 billion had evidence of past or present infection. In Saudi Arabia, the estimated prevalence between 2 to 4%. So most people get hepatitis B infection early in their life, and the patient will go into what's called immune tolerance phase, where the body does not recognize the virus. And at this phase, there will be high replication of the virus, but there's no injury to the liver. That will last for months or maybe years, and for a reason not completely understood, the patient will go into what's called immune clearance phase, where your immune system tries to clear the virus. At this time, there will be fluctuation of hepatitis B DNA, as well as fluctuation in the liver enzymes. And then the patient might go into what's called immune control phase, where the hepatitis B DNA will become undetected, ALT will normalize, E antigen will be changed, will be converted to E antibody, and if the patient is lucky enough, the surface antigen will be converted to surface antibody as well. So as Dr. Cow mentioned, the issue now with hepatitis B virus that you actually don't get rid of hepatitis B. When a patient gets infected with hepatitis B, the cccDNA of the virus will be incorporated into the hepatocyte, and that will lead to persistent infection of the hepatocyte. So even in patients who are considered as immune or had resolved infection, they are still at risk of infection. In normal circumstances, the immune system will be capable to remove any viral replication. During immune suppression, such as in patients receiving high-dose steroid, in patients who are receiving chemotherapy, the immune control will be lost, and the viral replication will not be controlled by the body. Then the patient will have hepatitis B reactivation. So what's the definition of hepatitis B reactivation? There's no universal definition among literature. In a special meeting arranged by the ACLD in 2013, they suggested this definition for hepatitis B reactivation. In patients with hepatitis B surface antigen positive, it's a significant increase in hepatitis B virus replication, and they define that as increased by more than 2 logs. Although lots of literature, they talk about only 1 log as a significant increase in viral load. A new appearance of hepatitis B DNA in patients who were negative. In patients who were hepatitis B surface antigen negative and core antibody positive, reverse seroconversion is considered reactivation or a new appearance of hepatitis B DNA. So the problem with hepatitis B reactivation is not only a viral breakthrough. This is a proposed grading by Dr. Jordan Feld and Versam. There are 3 parameters are considered important during evaluating patients who had hepatitis B reactivation. So other than the viral breakthrough, the amount of liver injury, which can range from no hepatitis to mild or severe hepatitis, and in severe cases, even liver failure. And the other important question, what's the consequences of hepatitis B reactivation, which is very important to our oncology colleagues. The consequences maybe there's no consequences, or that might lead to reactivation might lead to interruption of immune suppression or even complete discontinuation. Hepatitis B reactivation goes into 3 phases. The first phase, this is during immune suppression or chemotherapy, where there will be an increased hepatitis B virus replication with no evidence of any liver damage. Then in between chemotherapy, during the immune reconstitution phase, the liver injury phase happen, where there will be increase in the liver enzymes, including ALT and bilirubin. The patient might have symptoms mild to and might be even severe hepatitis, and in some cases that might lead to liver failure. If the patient is lucky enough, we'll go into the third phase, which is the resolution phase, where everything will go back to the baseline. So these are the different causes of hepatitis B reactivation. I will just focus on immune suppression for autoimmune diseases. So the 2 most important risk factors for reactivation are the hepatitis B serology status of the patient, as well as the type of immune suppression. The AGA published the guidelines on hepatitis B reactivation in 2015, and they categorize the immune suppression into 3 levels in terms of risk of reactivation. High risk, such as anti-CD20, such as rituximab. High-dose corticosteroid is considered high risk, and that's defined by steroid equivalent to bread more than 20 milligrams for more than 4 weeks, systemic chemotherapy. Intermediate risk, such as anti-TNF, moderate dose corticosteroid, as well as integrin inhibitors. Low risk, such as methotrexate and azathioprine. This is basically showing the same thing. Bone marrow transplantation, B-cell depleting agent, as well as high doses corticosteroid are considered the major risk factor for the activation. Anti-TNF is considered intermediate risk for the activation. Antimetabolite are low risk for the activation. So steroid, there is cumulative evidence showing that steroid carry a significant risk for the activation. In this study, they had a patient who had non-Hodgkin lymphoma with surface antigen positive. They were randomized into 2 groups. Patient who actually received chemotherapy without steroid, and the second group received chemotherapy with steroid. And as you can think, hepatitis B reactivation as well as severity of the activation were much higher in patients who received steroid, but after 4 years of follow-up, the survival was actually the opposite. Patients who did receive steroid did actually better in terms of survival. The message of this, although steroid increased risk of and severity of hepatitis C activation, but there is a trend toward improved outcome in patients with non-Hodgkin lymphoma. So in these cases, although hepatitis B activation is a major risk, although steroids are considered major risk for reactivation, but in these cases, these need to be individualized based on the patient. Another study, a retrospective study, they had about 200 patients with surface antigen positive with asthma/COPD. All patients were on inhaled corticosteroid. It's a retrospective study. They looked at patients who did receive systemic corticosteroid in addition to their inhaled corticosteroid, and they looked at the risk of reactivation. And they compared intermittent versus continuous doses of corticosteroid and low dose versus medium to high dose of corticosteroid. And this study showed that continuous use of corticosteroid for more than 3 months and or high dose steroid, more than 20 milligrams of prednisolone, increased risk of reactivation. So switching gears to anti-TNF agents, there are multiple studies looked at the risk of reactivation who are planned to undergo anti-TNF treatment. So in the first study, it's a systematic analysis of reported cases. The risk of reactivation was quite high. It's about 39%. 5 patients had actually liver failure, and 4 of them died. Another study in IBD patient, the risk of reactivation reached up to 36%. In 2 other studies in patients with rheumatological diseases, the risk of reactivation was between 7 to 12%. How about anti-TNF in patients who have hepatitis B core antibody positive and surface antigen negative? The risk is significantly lower than patients who are surface antigen positive. In the same study, the systematic analysis of reported cases, the risk of reactivation was about 5%, and 1 patient died because of hepatitis B reactivation. Another study, it's a meta-analysis of retrospective studies. The risk of reactivation was about 1.7%. Interesting, in 2 prospective studies in patients with rheumatological diseases, although patients were given more than 50% of patients received another agent, another immune suppressive drug in addition to anti-TNF, the risk of reactivation was reported to be 0. So rituximab is considered a major risk factor for reactivation because it causes profound loss of hepatitis B surface antibody production. In a study looked at a patient with diffuse large B-cell lymphoma and core antibody positive. Patients were randomized into 2 groups, patients who are going to receive CHOP therapy without rituximab versus the other group who are scheduled to have rituximab. Hepatitis B reactivation was significantly higher in patients who were given rituximab. So this meta-analysis looked at the same idea of rituximab use in patients who had hepatitis B core antibody positive. The overall rate of reactivation was 6.3%. In this meta-analysis, they compared prospective versus retrospective studies. In the prospective studies, the rate of reactivation was much higher, reaching up to 14.3%. In the same study, they looked also at the presence of hepatitis B surface antibody as a protective against hepatitis B reactivation. Although the B value was not significant, but there was a trend toward lower risk of hepatitis B reactivation. Another study looked at hepatitis B surface antibody as a protective against hepatitis B reactivation in patients with core antibody positive receiving rituximab. So in this study, they had 63 patients. 19 of them did have reactivation of hepatitis B. In the first graph on the left side, they looked at absence or presence of hepatitis B surface antibody and showed that presence of hepatitis B surface antibody is protective against hepatitis B reactivation. And then they compared the titer of the hepatitis B surface antibody, they looked specifically at titer more or less than 20 and more or less than 100. The p-value was not clinically significant, so the conclusion was undetectable antibody was the only risk factor, but baseline level was not statistically significant. For that reason, the AGA suggests against routine use for anti-hepatitis B surface antibody titer to guide antiviral prophylaxis for all at-risk groups. We're all excited about the new antiviral treatment for hepatitis C. The FDA has issued a black box warning in October of 2016. That's based on 29 cases who actually did have hepatitis B reactivation after starting direct-acting antiviral. Most of the patients did have hepatitis B surface antigen positive. 3 patients were surface antigen negative and core antibody positive. They reported 2 deaths. 1 patient needed liver transplantation, and the reactivation was severe enough in 8 patients to require discontinuation of DAAs. The reactivation happened, in the reported cases, the reactivation happened between weeks 4 and 8. So the FDA suggested that physicians should screen all patients with hepatitis B surface antigen and hepatitis B core antibody before initiating anti-HCV medications. So the question now, what do we do with patients who have hepatitis B surface antigen or core antibody positive before initiating therapy? The AASLD recently, in their guidelines, suggested that patients who have hepatitis B surface antigen positive and need treatment for hepatitis B according to their guidelines to get treated for hepatitis B. If the patient does not meet the criteria for treatment, patient just need to be monitored over time. Switching gears to management of patient at risk of reactivation. So there are lots of studies comparing preemptive versus on-demand therapy, and most of these studies suggested that preemptive therapy is superior than on-demand treatment. This study is unique because there are 2 lessons from this study. In this study, there are patients with non-Hodgkin lymphoma treated with CHOP therapy. The patients were randomized into 2 groups, patients who are planned to have on-demand treatment. So if the liver enzymes increase by more than 1.5 upper limit of normal, they will be started on lamivudine. The other group will be started on lamivudine from day 1 and will continue for 2 months. So as you can imagine, hepatitis B activation was significantly lower, as well as the severity in the patient who received preemptive treatment. But interesting enough, the patient who did actually receive preemptive treatment did have more mortality than patient who did not have. The reason for that was the treatment was given only for 2 months. So the important lesson from this study that duration of prophylaxis is very critical as well. Another study looked at treating patients with hepatitis B core antibody receiving rituximab, mainly on-demand treatment. So what they did, they had 150 patients enrolled. They were treated with rituximab-based therapy. The patient did have blood work done before every chemotherapy and every 4 weeks afterward. 17 patients did have reactivation. They were started on entecavir, and no patient died because of reactivation. So their conclusion is the reactivation was about 11%, no hepatitis-related death. There was delay in chemotherapy in 2 patients. I think from this study, although on-demand treatment was safe, but I think for most of us, it's inconvenient to bring the patient every 4 weeks for labs. So hepatitis B reactivation rely on 2 factors. The first factor is the type of immune suppression, as well as the hepatitis B virus serology of the patient. So in patient with hepatitis B core antibody positive, using anti-CD20, or if the patient are planned to go stem cell transplantation are considered at moderate risk for the activation. It's been suggested that the patient need to be to receive prophylaxis.
Mohammed,
Otherwise,
2 minutes, please.
Otherwise, they don't need prophylaxis. In patient with surface antigen positive, they are considered at moderate to high risk if they are planning to undergo any type of immune suppression except conventional immune suppressant such as methotrexate or azathioprine. This is the AGA guidelines on the management. I think it's a very busy slide. I want you to focus on the moderate risk. Anti-TNF in patients with core antibody positive are considered intermediate risk in these guidelines, and they suggested prophylaxis over monitoring. In a Nature Review article by Dr. Analog and Huang, they considered anti-TNF in patients with anti-core antibody positive as a low risk, and the patient does not need prophylaxis. So duration is very critical. So the AGA and ASCO guidelines suggested at least 6 months of prophylaxis post-discontinuation of immune suppressive therapy in patients who are planned to receive rituximab to continue on treatment for 12 months. EASL and ABASL suggested to continue on treatment for 12 months after discontinuation of therapy. So going back to the cases, the first case, anti-TNF for hepatitis B surface antigen positive. I think the patient needed prophylaxis with antiviral therapy. The next case, anti-TNF for patient with core antibody positive and surface antigen negative. I think B and D are reasonable answers, but I'm favoring monitoring over treatment for those patients. In patients who are planned to go rituximab with core antibody positive, I think the patient needs prophylaxis with antiviral therapy. So in conclusion, hepatitis B reactivation can be serious and fatal. Screen at-risk patient with surface antigen and core antibody plus or minus DNA. Patient with the so-called resolved infection can be at high risk of reactivation in certain circumstances, such as anti-CD20 agents or stem cell transplantation. DAAs are not completely innocent drugs and can lead to reactivation. Thank you.
Thank you, Mohammed.